class, I'm going to begin this online lecture in week 7, day 2, with the concept of metabolism. And our first exemplar is hyper and hypothyroidism, okay? And up in front of you, I have a PowerPoint just to kind of refresh your knowledge about the thyroid gland and as to what hormones are secreted and what happens when there's an excess of the secretion of hormone or an under secretion of this hormone, okay? And I first want you to kind of review a little bit about your A&P of the thyroid gland and what hormones are produced, because that's really how you get to understand some of these endocrine functions, okay? There is a YouTube video that we put on the weekly lesson plan that I hope you're able to review, because the thyroid is absolutely one of the most important glands and is essential for life, and you have to kind of think about where that thyroid gland is and where it sits, and to remember that it is a very, very vascular organ as well. All right, so let's talk about the thyroid gland, okay? First of all, let's look at hyperthyroidism. And what happens with hyperthyroidism is there is an increased circulating level of thyroid hormones, okay? And I hope you can remember and go back to understand the incredible complex reactions that occur in order for the secretion of the thyroid hormones to be kind of secreted out. And because there is a excessive delivery of these thyroid hormones, we now have this very, very increased metabolic rate. And these hormones really do affect every system in the body. And this can be a very dangerous situation when it is not recognized that the person themselves and the amount of stress that's put on all these various systems, especially the cardiac and the respiratory system. So it does heighten the sympathetic nervous system's response, and we're going to talk about the different types of hyperthyroidism as well, okay? It can be caused from any type of autoimmune stimulation, excess secretion of thyroid stimulating hormone, or also an excessive intake of thyroid medications. So let's look at who's at risk for developing hyperthyroidism. So women are definitely at an increased risk for hyperthyroidism, being about 8 times more likely than men to develop hyperthyroidism. Genetic factors play a role, such as the family history, especially if someone in the family has a form of hyperthyroidism known as Graves' disease. And other factors may be increased iodine intake and being between the ages of 20 and 40 years of age. So let's look at what happens to the person when they develop hyperthyroidism. What kind of clinical manifestations will we begin to see with this patient? Now, one thing the patient will talk about and complain about is they have quite an increased appetite, but even though they're eating more, they're still continuing to have a lot of weight loss. Increased peristalsis, hypermotility of the bowels, so they'll definitely have diarrhea. heat intolerance. And because of this high metabolic rate, the person will suffer from insomnia, just very hard for them to relax, settle down, and even to get to sleep. Cardiac-wise, they're going to feel palpitations, increased sweating, hair changes begin to occur. The hair may start to become very fine, and sometimes a person may also complain of hair loss in the scalp, in the eyebrows, the axillary, or even in the pubic areas of the body. And one thing that will definitely be noticed, especially by family and friends, is the change in their mood. A lot of these people will start to develop this emotional lability, which means that they're just very hyper excited all the time. They might be very emotional. They might cry a lot. They might yell a lot. And this may be the first clue that something is very seriously wrong, because the person that they're living with, a spouse, children, may notice a real change in their personality. Okay? So let's talk about the different types of hyperthyroidism. Okay, the first one is Graves' disease, and this is really considered to be an autoimmune disorder, sometimes associated with other autoimmune disorders. Maybe the person might have rheumatoid arthritis. And what happens is these people with Graves' disease have an antibody in their serum that binds to those TSH receptors in the thyroid follicles, and it causes the thyroid cells to hyperfunction. And when this antibody does bind to this thyroid stimulating hormone receptors on the thyroid gland, it stimulates hormone synthesis and secretion, which causes an enlargement of the thyroid gland, and we know that more commonly as a goiter. And the cause is unknown, but they do find that people in the family that have had this presents as a hereditary link. Okay, so patients with Graves' disease have an enlarged thyroid gland and definitely show all those manifestations that I just talked about. And that goiter can result from excessive thyroid stimulating hormone stimulation, and when the amount of that circulating TH is deficient. And one thing that you will see that is quite obvious with these patients is this ophthalmology, which is where they have this disease of the eye that's manifested as proptosis and visual dysfunction. And what proptosis is that forward displacement of the eye, and that only occurs in about 1/3 of the cases. And it's also known as exophthalmos, and you'll see that the eyes are kind of forwardly pushed outward or kind of protruding out. And why does this happen? What occurs here is there's an accumulation of the inflammatory byproducts in the retroorbital tissues of the eye. And many times you'll see that the sclera is visible above the iris. And the upper eyelids are often retracted, and the individual has that characteristic blinking, or I should say unblinking stare, where they just kind of stare at you, and it's kind of a creepy look. And it's kind of very alarming when you look at this, but it's something that is very, very noticeable, okay? The proptosis usually is bilateral, but sometimes it can only just affect one eye. And the problem with this is the patient starts to have visual difficulties as well. They can have blurred vision, diplopia, where they see double vision, eye pain, lacrimation, where they really have excessive tearing, and photophobia, where they're very sensitive to the light. And what happens is they're unable to really close their eyelids completely. because the eyeball seems to be protruding outward. And so this may unfortunately cause the person to develop this corneal dryness, a lot of irritation, infection, and even ulcerations of the eye. An infiltration of the muscles that move the eye and of the optic nerve can actually lead to paralysis and vision loss. The treatment of Graves' disease may stabilize, but these symptoms generally do not reverse once the changes in the eyes have occurred. So finally, they do diagnose a person to be hyperthyroid. They put them on some medication. And unfortunately, it's not like their eyes will go back to the way they used to be. Now, sometimes when this ophthalmos is extremely quite evident, and there's really difficulty in closing those eyelids, surgery can be done to actually take those eyeballs and set them back more into the eye socket. Along with these eye problems, the patient will definitely be very fatigued because their body is in this hyper metabolic rate. You'll start to see hand tremors. When a woman is, young enough to menstruate, there will be changes in menstruation. Maybe they'll have a decreased flow to the point where they don't menstruate anymore. And some of the older patients may develop cardiac arrhythmia, such as atrial fibrillation, might also have angina, or also congestive heart failure. This can seriously affect a woman's ability to conceive. And with this, we have known that women who do have are really unable to get pregnant, they'll do a workup on their thyroid, because this could be the problem as to why they're not able to get pregnant, because there has been known to have women have decreased fertility, no periods at all, and definitely irregular periods. And also hypothyroidism is also correlated with increased spontaneous abortion. So if a person has been pregnant and then diagnosed with hyperthyroidism, we've seen the increased risk of, a spontaneous miscarriage. So that's hyperthyroidism due to Graves' disease. Graves' disease is caused by that autoimmune disease, okay? So the next reason why someone may develop hyperthyroidism is due to toxic multinodular goiter, okay? And this, what happens with this is there's actually a thyroid tumor that is like a very small, discrete, functioning nodule in the thyroid gland that secretes excessive amounts of thyroid hormones, okay? And people really don't understand why these particular nodules begin to grow, but sometimes it's known that a genetic mutation of the follicle cells is suspected of being the cause of why this happens. Despite the fact that you have elevated thyroid hormones, this type of hypothyroidism really develops very slowly, and that's very important. You don't see a person with toxic multinodular goiter develop ophthalmos or dermopathy as well. And what we mean by dermopathy is it just means that you're going to see some skin changes that occur because the blood vessels that supply the skin nutrition and oxygenation begin to change as well. So that's what dermopathy is about. Usually the age is somewhat different for a person that develops toxic multinodular goiter. They are usually women in their 60s or 70s who has had a goiter for a number of years. And these are most common in women who have gone through menopause and may present as both hypothyroidism and hyperthyroidism. All right, the next reason for hyperthyroidism is excess of TSH stimulation, and TSH stands for thyroid stimulating hormone, and this comes from our pituitary gland, the anterior pituitary to be more specific. And what happens is this is overproduced because this is what causes that particular hormone to stimulate the thyroid to secrete thyroid hormones. So there is an overproduction of this hormone by the pituitary, usually that stimulates the thyroid gland to produce excess thyroid hormones. And the reason this happens is it's usually due to a fact that there's an adenoma or a tumor in the pituitary causing this excess stimulation or excess secretion of TSH. But it is more of a rarer form of hyperthyroidism. And then the next one is thyroiditis. And all this is an inflammation of the thyroid gland itself, usually caused by some type of viral infection of the thyroid gland. And when this occurs, you have the secretion of increased, thyroid hormones. Usually it's an acute disorder, but can eventually become chronic, resulting in a hypothyroid state, as repeated infections will start to destroy the gland. And just to add a little bit to this, sometimes this thyroiditis can actually be caused by bacterial infections as well, where the person could be put on some type of antibiotic. So it can be caused by both viral and bacterial as well, even though your book just talks about the viral. But if this recurs frequently, as the book says, it will eventually destroy the gland tissue, causing your patient to then become hypothyroid, okay? So let's talk about this next problem called thyroid storm. All right. I personally, in my whole career of nursing, have never seen a patient in a thyroid storm, but this is a very serious and dangerous, and it really is an emergency type situation because it's a very, very aggressive and heightened form of hyperthyroidism, and it is life-threatening. And usually this is a result of somebody who really ignores their signs and symptoms of hyperthyroidism, and it's usually because it's not being treated properly or some kind of really serious stressor may have caused the beginning of hyperthyroidism as well. What happens is that there's obviously a rapid increase in metabolic rate. And I do want to point out that because we have come so far with treating these patients with hyperthyroidism, that we don't see thyroid storms as much as we used to, because we're able to diagnose these patients early in their disease, and treatments are very successful, especially with the medications that we prescribe with these patients. And what do we mean by a stressor? A stressor could be anything from an infection, from a trauma, even someone who is a known diabetic who may have untreated DKA, or somebody that might have some type of manipulation of the thyroid gland during surgery. And as I said before, it's really important that a person recognizes that they're going into this thyroid storm and get to the hospital as soon as possible, because rapid treatment is essential. And the first thing we have to do is bring their temperature down, because you're going to see people with temperatures possibly as high as 105 to 107. So usually what they do is put on cooling blankets. We do not treat high temperatures with aspirin, because that actually increases the secretion of free thyroid hormones, or it actually will cause the situation to be even more serious. Obviously, with a temperature that high, they can become dehydrated extremely fast. So replacing fluids is essential, glucose, electrolytes, and relieve any type of respiratory distress that occurs, and definitely give medications to treat a lot of the cardiovascular function, especially high heart rates, which can lead to higher oxygen demand and lead to some life-threatening arrhythmias. And again, we have to be sure that we can stop the secretion of these thyroid hormones as well. So we want to suppress or reduce the amount of thyroid hormones that are being secreted. All right. All right. So anytime we have a patient that does have hyperthyroidism, our goal is to free them of their manifestations, because these can be extremely uncomfortable and very hard to live with. And again, preventing any type of complication because of the effect it has on some of these systems, such as the respiratory, the cardiac, and things like that. Most of the treatments that we do for these patients is to prevent the release or secretion of these thyroid hormones, or to try to destroy some or part or all of the thyroid gland. And if we do that, then it's necessary that these people will have to take lifelong hormone replacements to obviously make up for the hormones that are not being secreted by the thyroid. Now, since we have kind of destroyed that gland in performing the way it should. So let's look at diagnostic studies. How do we determine that a patient does have hyperthyroidism? Obviously, we look at our patient, a good assessment. What kind of manifestations do we see with this patient? It's obviously caused by excessive thyroid hormones and by what we conclude and analyze and determine from the diagnostic testing. The first thing is a TA test, and a serum TA is measured to determine whether a thyroid autoimmune disease is causing the patient's symptoms. And obviously, if they do have Graves' disease, this TA test will be elevated, and that stands for thyroid antibodies test. And then the next one is a TSH test, and that's a sensitive assay test. And this is where we look at thyroid stimulating hormone levels and compared with T4 levels to differentiate between, is this a problem that's happening in the pituitary, or is it a problem that's happening within the thyroid itself? So we want to determine if it's primary hyperthyroidism, which would be a problem directly related to the thyroid itself. So the best indicator of primary hyperthyroidism, such as someone that has Graves' disease, is suppression of TSH below a certain level. And then when the sensitive TSH is not suppressed, the hyperthyroidism is usually caused by a tumor in the pituitary itself. So there isn't a problem with the thyroid gland itself. And then we have T3 and T4 tests, just measuring the thyroid hormones, and then a T3 uptake test. Usually they mix the patient's blood with a radioactive T3, and the results are elevated in hyperthyroidism. And then the RAI uptake test, which is basically a thyroid scan, and it measures the absorption of 131I or 123I by the thyroid gland. And that is radioactive iodine uptake. And then they also do thyroid suppression test, and these are usually the RAI and the T4 levels are usually measured first, and then the patient then takes thyroid hormones for 7 to 10 days, after which the tests are repeated, and failure of hormone therapy to suppress RAI and T4 indicates that the patient does have hyperthyroidism. So what are we going to do for these patients that have been diagnosed with hyperthyroidism? How are we going to treat these patients? Okay. First of all, we do treat it with pharmacological therapy by giving antithyroid medications that reduce TH production. And I know you're learning about some of these in Nursing 123. We might also provide them medications to help bring down their heart rate because these cardiovascular symptoms can be very taxing on the heart, increasing oxygen demand, and puts that person more at risk for developing some type of arrhythmia. So maybe that person may be put on some type of beta blocker to block that sympathetic stimulation. And then, of course, radioactive iodine therapy is another type of treatment for patients with hyperthyroidism. And what they'll do is they give this RAI, radioactive iodine. It's given orally, and the results typically occur in about 6 to 8 weeks. And in most instances, the patient is not hospitalized and does not require any type of radiation precautions. We would not give this to someone who is pregnant who develops hyperthyroidism because it does actually cross the placenta and can have very serious effects on the developing fetus. And what happens is this radioactive iodine will begin to destroy the thyroid gland. And what happens is we can't really control how much of the gland we want destroyed, so the patient then can become hypothyroid. Okay? And this is why we begin to teach our patients about measuring their pulse rate, just so they can be aware of, cardiac functioning, because they may need additional medications to help slow down that heart rate. Another thing that may be done is surgery, and because a lot of our patients who do have hyperthyroidism have enlarged thyroid glands that actually press on the esophagus and the trachea. That's why I said, think about where the thyroid gland is located. It's really situated in close proximity to a lot of very important structures, such as the esophagus, the trachea, the carotids. So this is why our people with hyperthyroidism can have a lot of problems with breathing and swallowing. So what might be done with these people is a thyroidectomy, which is removal of all or parts of the gland. And if it's just parts, we might call it a subtotal thyroidectomy. And if it's removing the whole gland, we might call it a total thyroidectomy. Okay? We usually take out the whole thyroid gland if the person has been diagnosed with cancer. And then if that happens, the person will need to have a lifelong hormone replacement. And what they'll do is, before doing thyroid surgery, because it is a very vascular organ, they will give antithyroid drugs to help decrease the vascularity and size of the gland, which decreases the chance of hemorrhage after surgery. Because think about it, if this person hemorrhages during surgery, where do you think that blood's going to go? It's going to go down in the lungs, and it could cause severe respiratory distress as well. And so we look to these patients after these types of interventions and treatments to really have the patient understand, how are they feeling? Because a lot of these treatments don't see results immediately, okay? Many times we'll notice that the patient really doesn't start to feel better until a few weeks after they've been started on some of these therapies. Goals may include that the client will report improvement, describe situations requiring contact with provider, and really great, excellent teaching about taking prescribed medications, okay? And again, in the meantime, we're monitoring cardiac output as well as blood pressure, pulse rhythm, respiratory rate, breath sounds, suggesting keeping environment cool, free of distractions, and encouraging a balance of activity with rest. And of course, promoting balanced nutrition, monitoring nutritional status, having the patient weigh themselves daily, teach about diet needs such as high carbs, high protein, between meal snacks, and again, to improve body image, establishing trusting relationship, and encouraging patient to verbalize feelings, and really looking at their moods as well. How are they feeling? How is that level of excitement versus depression? What's their lability like? And many times that can be very, very honestly answered by family and friends. All right, class, now we're going to look at hypothyroidism, okay? And hypothyroidism is just the opposite. It is a disorder that results when the thyroid gland produces insufficient amounts of TH. And many times you'll see with hypothyroidism that the thyroid gland will start to enlarge to compensate for the attempt to produce more of these hormones. And we might also hear that with hypothyroidism, the state in adults is sometimes called myxedema. And this term reflects that accumulation of non-pitting edema in the connective tissues throughout the body. And remember that this edema is the result of water retention in mucoprotein deposits in the interstitial spaces. And the person that has myxedema will appear puffy, the tongue is enlarged, and the voice is hoarse and husky. Okay? So let's go on and talk more about this. So let's think about where this all originates from. Now, hypothyroidism can either be primary, which means that it's a direct problem with the thyroid gland itself. And this one is obviously more common. It can be caused by congenital defects in the gland, loss of thyroid tissue. Maybe the person was once hyperthyroidism, and the person had some type of surgery or radiation which made them now hypothyroid. It can be due to antithyroid medications, thyroiditis, or endemic iodine deficiency. And again, the secondary is a problem with the pituitary. And it will be a problem with pituitary TSH deficiency or a peripheral resistance to the thyroid hormones itself. Okay? This can occur anytime in life, but it's more common in women between the ages of 30 and 60 years old. The incidence will rise after a person reaches age 50. A lot of people ignore these signs and symptoms of hypothyroidism because they think it's more of symptoms that are associated with getting older. Okay. So who's at risk of getting to be hypothyroid? As I said before, it's more common in men and women older than 50, and anybody who has a close relative with an autoimmune condition, and anybody who's had any type of thyroid surgery, received any radiation to the neck, or has been treated with RAI or antithyroid medications. Other factors that will decrease thyroid hormones is obviously iodine deficiency and Hashimoto's thyroiditis. Now, I just want to kind of say something about hypothyroidism. When you talk about both of these conditions, such as hyperthyroid and hypothyroid, when you're hyperthyroid, because we're trying to decrease the secretion of thyroid hormones, there's always that potential to make a person hypothyroid. Does that make sense? Because if we're trying to stop the secretion of thyroid hormones, we might overtreat it, causing the person to become hypothyroid. And the same goes for someone who is hypothyroid. They're lacking those thyroid hormones. So we provide thyroid hormones, and maybe we just don't get it right, and we kind of overtreat that and make the person or the patient hyperthyroid. So there's always that possibility, and sometimes it really takes a lot of finagling and manipulation of their treatments to get them to be euthroid, or to have a good balance of these thyroid hormones to prevent them from manifesting symptoms of hypo or hyperthyroidism. So that's something I just wanted to really stress. This is these are very difficult conditions to treat, and hypothyroid, you want to make sure that you're not giving too much of these thyroid hormones. And usually we treat it with medications, and we'll talk about that in just a few minutes. But still, it may take a while before we get it just right. And that's why people have to be very aware of how they're feeling. And a lot of times the results do not happen immediately. It may take a few weeks before we see some kind of returning to a normal way, or not feeling those horrific symptoms as they do with hyperthyroidism as well as hypothyroidism. Okay, and you do need iodine to make thyroid hormones. That's why years ago, in the 40s and 50s, we used to see people with a lot of goiters because they were lacking iodine to make thyroid hormones, and they were probably hypothyroid. All right. Why has that changed? Why do we not see so many people with iron deficiency? Because we've added iodine to our salt, and that has alleviated a lot of people from developing hypothyroidism. But there is always a possibility that iron deficiency can occur, and iodine is necessary for synthesis and secretion of thyroid hormones. And sometimes we can see iron deficiency occur because of certain drugs, which actually block thyroid hormone synthesis. And that might be somebody who's on drugs such as lithium, which we give to some of our patients who have bipolar mental disorders, or some of the antithyroid medications. So, and then there's parts of the world where the soil is deficient in the iodine, and so their dietary intake of iodine may be inadequate. So that's what we mean by iron deficiency. Okay, so let's talk a little bit about Hashimoto thyroiditis. This is probably the most common cause of goiter and primary hyperthyroidism in adults and children. And it's also another autoimmune disease, but is related to someone who becomes hypothyroid because of it. And this one, antibodies develop that actually destroy the thyroid tissue, and that functional thyroid tissue is replaced with fibrous tissue, and that's when your thyroid hormones will start to decrease, and people will start to display symptoms of hypothyroidism. And this, as the disease begins to progress, you're going to notice too that the thyroid gland will become smaller. And this disease is more common in women than in men, and it also has some type of familial link as well. So let's see how these patients present who develop hypothyroidism, okay? It's a very slow onset. That's really important to know. People just start to notice certain things, but really don't think too much of it. Like I said, older people just attribute it to getting older, and those are just the way you're supposed to feel. These symptoms can start to manifest over months or even years. Some people may notice a goiter. They may have fluid retention and edema, decreased appetite, weight gain, constipation, dry skin, and dyspnea. These are some other additional manifestations: pallor, hoarseness, muscle stiffness, decreased taste and smell, menstrual disorders, anemias, cardiac enlargement, and abnormalities in lipid metabolism. And a lot of these people that do have hypothyroidism will have high cholesterol levels, and it's very serious, especially for our women population, because this does put them more at risk for cardiovascular disease as well. And again, as we talked about thyroid storm with hyperthyroidism, we need to address myxedema coma, which is more of an aggravated form of hypothyroidism as well. It's a life-threatening complication of someone that has had hypothyroidism for a long time and has not been treated for it. And it's usually triggered by an acute illness or trauma. And this is when they have severe metabolic disorders, and this is when they start to have some very serious electrolyte imbalance, such as hyponatremia, hypoglycemia, lactic acidosis, hypothermia, cardiovascular collapse. They also have impaired mental capabilities and can also move into a coma state. It's very rare, but usually it occurs most commonly during the winter months in women who do have chronic hypothyroidism. And this can be precipitated by a trauma, an infection, and even someone who just forgets or does not take their thyroid medications that's not compliant, even taking other medications such as central nervous system depressants and exposure to cold temperatures. Again, we have to treat the conditions, especially the ones that affect oxygenation and respiratory. So again, maintaining a patent airway and maintaining fluids, electrolyte and acid-base balance, and maintaining cardiovascular status, and getting their body temperatures up, okay? Because usually they're extremely hypothermic, and we got to get those TH levels up. And usually these patients are given IV medications of Synthroid and things like that. So let's look at diagnostic testing with hypothyroidism. Obviously, it's because of a decrease in TH, thyroid hormone, and TSH may be increased because what's happening is the hypothalamus is sending out the hormone to stimulate the pituitary, and so it keeps sending abundant amounts of TSH out to stimulate the thyroid gland itself, and that's why you'll see elevated TSH, okay? Because this whole process and these reactions is caused by negative feedback, and unfortunately when the TSH levels are increased, the negative hormonal feedback from thyroid hormones is definitely not there, okay? And again, we'll see the same diagnostic testing used to diagnose hyperthyroidism, also used to diagnose hypothyroidism. And again, there are pharmacological therapies where levothyroxine is used to treat hypothyroidism as well. The only time we would see surgical intervention is because maybe the goiter is extremely large and is definitely causing problems with swallowing and breathing. And this is where a subtotal thyroidectomy may be needed to ease the difficulty of problems like respiratory distress or swallowing or dysphagia. All right. These are the types of assessments you may find with a patient who has developed hypothyroidism: muscle strength, deep tendon reflexes, vital signs, cardiovascular, integumentary, thyroid gland, and weight. These are all things that we'll be checking, and they're going to be obviously the opposite of what we saw in our patients who had hyperthyroidism. Again, we want to definitely assess their cardiovascular status. We want to get their pulse and blood pressure within normal limits and not to be at risk for developing arrhythmias. Have skin that remains intact, warm and dry, free of edema, maintain visual acuity, and to be able to participate in activities and have normal heart rate. And really to definitely restore back that energy that they lose when this hypothyroidism begins to progress along the way. And of course their elimination returns to normal where they won't be suffering from constipation. And again, maintaining skin integrity, monitoring skin redness, lesions, and provider teach a mobile patient measures to promote circulation. Teach, implement, schedule of range of motion exercises, and provider teach patient measures to maintain skin integrity. And I also want to add too that we need to teach people the importance of being compliant with their medications if that's the way we're treating their hypothyroidism. They've got to be on that medications on a daily basis. It's the only way we're going to be able to get these patients to return to some degree of normalcy. And it's important too they follow up with their physicians as well to make sure that they're on the right dosage. That's why they have to really pay attention to their symptoms to see if they are getting better. Like I said, it doesn't happen overnight, but they have to be able to assess their elimination, their heart rate, maybe even take their own blood pressures just to determine if they're on the right medication or they're on the right therapy for treatment. All right, that pretty much sums up metabolism that's concerned with the thyroid function of patients developing problems with either hyperthyroidism or hypothyroidism. And I do want to remind you to please refer to page 869. There's a very nice picture of all the multi-system effects of hypothyroidism, and it explicitly talks about each system and what manifestation the patient will definitely exhibit. So please go over these. Obviously with respiratory they can develop pleural effusion. GI, they develop constipation. Musculoskeletal, muscle stiffness, weakness, fatigue. Neurologically, hand and foot paresthesia. Lethargy, somnolence, confusion, decreased reflexes, slow speech, and memory impairment. Sensory is periorbital edema, and cardiovascular is hypotension, bradycardia, dysrhythmias, an enlarged heart, and anemia. And reproductive is menorrhagia, infertility, decreased libido for males, and integumentary, hair loss, brittle nails, coarse dry skin, and non-pitting edema, and they become very hypothermic, anorexic, weight gain, and systemic edema. So that's for hyperthyroidism. And then on page 863, just the opposite of these multi-system effects of hyperthyroidism. Both will have a goiter, and they can develop dyspnea. And GI is a lot of nausea, vomiting, diarrhea, or abdominal pain. And musculoskeletal, they will have muscle wasting, loss of strength, fatigue. Neurologically, hand and eye tremors, nervousness, insomnia, emotional liability, and increased reflexes, anxiety, blurred vision, photophobia, lacrimation, and exophthalmos, especially if they have Graves' disease. And then cardiovascular, hypertension, tachycardia, dysrhythmias, and palpitations, and reproductive amenorrhea, absence of menstruation, decreased fertility, decreased libido, impotence in males, erectile dysfunction, and azoospermia. Hair loss, increased perspiration, hyperthermia, diaphoresis, hunger, weight loss, and fluid volume deficit. So be sure you look at those. These are very helpful in helping you to determine what's going to happen with these patients when they have excessive thyroid hormones as opposed to a decrease in thyroid hormones. And it might be good to go back and look at your anatomy and physiology and really understand how this very complex reaction occurs, because it all starts up in the hypothalamus, which stimulates the pituitary, which then stimulates the gland itself, such as the thyroid gland, to secrete those hormones, which is essential for life. Now that we have talked in great length about a function of the thyroid and these two conditions that can be very serious, hypothyroidism and hypothyroidism, let's look at this case study about a patient who has hyperthyroidism. Judy Smith is a 55-year-old female who has recently returned to the United States after a lengthy missionary assignment in South Africa. She arrives at the provider's office today requesting a head-to-toe physical exam, including a pap smear and mammogram. Ms. Smith has been reassigned to serve in the Fiji Islands, where health care is scarce. She would like a full workup. Temp is 99, pulse is 112, respiration is 22, and blood pressure is 134/92. Her height is, she's 5 foot 2 inches, and her weight is 101 pounds. In overall appearance, she's thin, older looking than her stated years, wispy gray hair and a matted bun. You note that Miss Smith has a visible goiter, and as you question her about it, she states, "Oh, I've had that for a long time. My mother had one too." She states that she has been going through the change of life for the past 5 years and is having frequent hot flashes. She has lost 10 pounds over the last few months from what she describes as self-imposed caution when eating in third world countries. As Miss Smith is talking, you note she has a slight tremor as she pushes her hair out of her eyes. Her face is flushed and she is fanning herself throughout the interview. She's anxious and fidgets a lot. Her hair is thin and shiny, and her goiter is palpable, which has caused an enlargement of her neck. She denies sleep apnea, but states that she does snore. So, what focused health history would be appropriate to elicit from Ms. Smith? And I think you're all thinking what I'm thinking, that she does have hyperthyroidism just by her picture-perfect manifestations of this problem with her thyroid. I would want to definitely know what country she has been in and what diseases are prevalent in that country. Has she received any type of immunizations, or did she have any illnesses while she was there? Any important health history from before she went to Africa would be very helpful. All right, let's look at question 2. What physical assessment would you perform to obtain a complete picture of Miss Smith's status? Obviously, a health history, family history, anybody who might have had thyroid disease in her family. When did she first notice the goiter? When did she first notice symptoms? What medications does she take? When did she notice changes in her weight and in her menstrual history? And then you could further assess things like muscle strength, tremors, vital signs, lung sounds, heart rate and rhythm, peripheral pulses, skin condition, the size of her thyroid, and the presence of a bruit over the thyroid. So these are all things that we could further follow up on. But she really does present as a very classic person who does have hyperthyroidism. Okay. All right. All right. Let's move on to the next case study. Okay. Oh, first of all, let's take a look at osteoporosis first. All right, before we talk about osteoporosis, I want to just do some review questions on the thyroid. So let's go over these together, okay? Question 1. Which of the following statements made by a client would indicate to the nurse that the client understands the instructions to follow prior to a blood draw for measurement of a serum cortisol? All right, our choices are: I'll plan to stop at the lab on my way home from work and I won't eat or drink anything after lunch. Or 2, I should have the blood drawn first thing in the morning after a good night's sleep and after breakfast and my morning coffee. And number 3, I'll plan to visit the lab on my lunch break from work before having anything to eat. And number 4, thank goodness I don't have to have enemas. So I know it's dealing with cortisol, but it is an endocrine problem or an endocrine hormone. But this can kind of go for a lot of the labs that are drawn to diagnose some of these endocrine problems. And the answer is I should have my blood drawn first thing in the morning after a good night's sleep and before breakfast and in my morning coffee. And the rationale behind that is the client should not eat or drink and should rest for 2 hours before the test. To stop on the way home or to have the test during a work time lunch break would preclude the client from resting for 2 hours prior to the test. Further, the client who plans to take the test on the lunch break makes no mention of the need to abstain from fluids as well as food prior to the test. All right. All right, so let's do number 2. All right. Which of the following methods would be the preferred method to use when performing physical assessment or palpation of the thyroid gland? And the choices are: number 1, stand in front of the client, place fingers above the trachea, have the client flex the head, and ask the client to swallow. Number 2, stand in front of the client, place fingers slightly above the thyroid cartilage, and have the client extend the head and swallow. Number 3, stand behind the client, place the fingers on either side of the trachea below the thyroid cartilage, and have the patient tilt the head to the right and swallow. And number 4, stand behind the client, place the fingers above the jugular notch, and have the client extend the head and swallow. Usually as nurses, we don't usually do this. This should be done by an experienced examiner, because if you palpate that thyroid and they're already hyperthyroid, you could actually secrete further hormones, which isn't a good thing for somebody who's already hyperthyroid. So the answer to that is number 3, stand behind the client, place the fingers on either side of the trachea below the thyroid cartilage, and have the client tilt the head to the right and swallow. All right, let's move on. And here's the rationale behind that. The nurse stands behind the client, places the fingers on either side of the trachea below the thyroid cartilage, and asks the client to tilt the head to the right and swallow. As the client swallows, the nurse displaces the left lobe while palpating the right lobe. The nurse repeats the process as stated, but displaces the right lobe while palpating the left lobe. The normal sized thyroid gland is not usually palpated. All right, so let's go to question 3. The nurse is assessing a client with newly diagnosed hypothyroidism as having an enlarged thyroid goiter. The nurse explains to the client that which of the following is the physiological reason for the goiter. Number 1, an excess of thyroid hormones that stimulates thyroid follicles. Number 2, an increased dietary iodine intake. Number 3, a compensatory effort to produce more thyroid hormones. And number 4, tissue hypertrophy in response to increased thyroid hormone. So think about this. Why do goiters occur? And it is a number 3, compensatory effort to produce more thyroid hormones. And here is the rationale. The body tries to produce more hormone by simply producing more cells that produce that hormone, hence a goiter. TH is decreased and dietary iodine does not affect thyroid enlargement. All right, so that pretty much concludes our practice questions for hypo and hyperthyroidism. All right, let's move on to our next exemplar of the concept of metabolism, which is osteoporosis. And let's look at what osteoporosis is. It's a metabolic bone disorder, loss of bone mass, increased bone fragility, and a person will have increased risk of fractures. The reduced bone mass is caused by imbalance in the processes that influence bone growth and maintenance, and it's most often associated with aging and inadequate calcium intake. And we can also pretty much define osteoporosis as porous bones. So let's look at the etiology behind osteoporosis. An estimated 57 million Americans have low bone mass or osteoporosis, and 80% are older women. One in 2 women and 1 in 4 men will have an osteoporosis-related fracture. And there are 2 types of osteoporosis, primary and secondary. Primary osteoporosis may be either type 1, which is associated with menopause, or type 2, which is associated with decreasing bone formation that accompanies the aging process. And when we talk about type 1, which has to do with menopause, it's been linked to estrogen deficiency, resulting in increased calcium reabsorption from the bone, as the lack of estrogen renders the body more sensitive to PTH. And type 2 osteoporosis really typically results as the kidneys lose their ability to process vitamin D, causing decreased calcium absorption, which in turn will increase the sensitivity to PTH and bone reabsorption. And again, calcium levels are definitely based on the function of PTH that comes from the parathyroid glands and from calcitonin, which comes from the thyroid gland as well. So let's look at the risk factors. Again, it depends on bone mass achieved, which means how much is achieved between the ages of 25 and 35, and afterward on how much bone mass is essentially lost. There are certain diseases, lifestyle habits, and ethnicities that also affect whether or not you will have osteoporosis. So let's look at the unmodifiable risk factors. Family history, age and gender, ethnicity, and other chronic diseases, current low bone mass in children as well. So let's look at family history, okay? People with a family history of osteoporosis are at increased risk for developing it themselves. And also those with a history of fracture in a first-degree relative are also at higher risk. Both men and women are susceptible to osteoporosis as they age because of the osteoblast and osteoclast undergo alterations that diminish their activity. Women, especially white women and Asian women, have a significantly higher risk for the manifestations and complications of osteoporosis because their peak bone mass is 10 to 15% less than that of a man. An age-related bone loss in men usually occurs 15 to 20 years later than women, but at a much slower rate. Estrogen in women and testosterone in men appear to help prevent osteoporosis, and so those decreasing levels as we begin to age contributes to that bone loss. So ethnicity, it's more common in Caucasian and Asian populations, and the incidence of osteoporosis and fractures of the hip and spine are lower in African American patients. And then again, let's look at modifiable risk factors. Okay. And the first one is female athletes. Okay. Menopause, calcium deficiency, acidosis, substance abuse, sedentary lifestyle, and medications. Okay. And we look at body weight, which does have to do with female athletes, and usually anybody who has a BMI that's less than 20, regardless of their age, whether or not they're male or female, or weight loss, is at greater risk for both bone loss and subsequent risk for fractures. And that might be our patients who have problems with eating disorders such as anorexia nervosa, and low body weight in female patients cause the body to stop producing estrogen, and underweight individuals have twofold increased risk for fracture when compared to people with BMIs that are greater than 25. Again, substance abuse is about cigarette smoking and excessive alcohol intake are risk factors for osteoporosis. Again, when we see someone smoke, it decreases the blood flow to the bones, and nicotine slows the production of osteoblasts and impairs the absorption of calcium. And alcohol has a direct toxic effect on osteoblast activity, suppresses bone formation during periods of alcohol intoxication. So clinical manifestations are, first of all, the most common manifestation of osteoporosis are loss of height. You have that progressive curvature of the spine, low back pain, and fractures of the forearm, spine, or hip. Osteoporosis is often called a silent disease because bone loss occurs without symptoms, and the problem may not be completely in front of that person until the patient has a fracture or they have an x-ray that show that they do have osteoporosis. So the loss of height occurs as the vertebral bodies start to collapse, and acute episodes generally are painful, with radiation of the pain around the flank into the abdomen. And this can happen with minimal movements such as bending, lifting, or jumping, and may precipitate the pain. In some patients, vertebral collapse may occur slowly, accompanied by just a little bit of the discomfort. And then along with loss of height, we have that characteristic dorsal kyphosis and cervical lordosis develop, which we call like the buffalo hump. And this here's a great picture of that on page 856 in your Pearson book, where you can kind of see what happens from the age of 40, 50, and 60. Okay? And we know that fractures are the most common complication of anyone who has osteoporosis, and this disease is responsible for more than 1.5 million fractures a year, which is really quite staggering. So how do we stop or slow this process and alleviate the symptoms and prevent complications and provide proper nutrition and exercise? Okay, that's a great question. First of all, we want to diagnose it properly, all right? And some of the diagnostic testing that we see are the dual energy X-ray, the DEXA, which measures bone density in the lumbar spine or hip and is considered probably to be one of the most highly accurate type of testing. Because many times the manifestations of osteoporosis can mimic those of other bone disorders. That's why we need to do these diagnostics tests to explicitly diagnose it as osteoporosis. Then we have ultrasound, which is of the heel to measure bone density, and ultrasound permits painless sound waves through the heel of the foot to measure bone density. And this 1-minute test is not as sensitive as your DEXA, but it is accurate enough for screening purposes. And then lastly, some of the lab tests that we take samples of blood to measure alkaline phosphatase, which may be elevated following a fracture, or serum bone GLA protein, which can be used as a marker for osteoclastic activity and could be an indicator at the rate of bone turnover. This is the test that's most useful to evaluate the effects of treatment rather than to indicate the severity of the disease. So what else do we want to do with patients with osteoporosis? Obviously, working with physical therapy to design appropriate exercise program, especially important for those with comorbidities such as COPD or asthma. Sometimes patients who have problems with balance may benefit from Tai Chi or yoga, both of which can benefit individuals with osteoporosis. If a nurse is working with a female athlete or suspects an eating disorder or amenorrhea, the nurse should discuss counseling and nutrition referrals with this patient. Dietary management is of utmost importance. Want to be able to teach people about choosing foods that are high in calcium and vitamin D, and some of these calcium-rich foods are dairy products, vegetables, and some beans, and also food supplemented with extra calcium includes orange juice, breakfast cereals, and breads. And foods rich in vitamin D include fish. Foods with vitamin D added include milk, cereal, and breads. And if inadequate calcium and vitamin D are found in the diet, patients may be ordered to take supplements to ensure that their body is getting enough of these particular nutrients. And again, we know that, part of the treatment is possible pharmacological therapy, and you're learning about these particular drugs in Nursing 123. Probably the most common drug classes for treating osteoporosis is your biphosphonates, but I'm not going to get into those because I know you guys are learning about this. So again, nursing assessment, health history, age, risk factors, looking at the patient, physically examine them to look at height, spinal curves, and to assess their spinal column as well. What are the goals in planning the care for an individual? Participate in weight-bearing exercises for 30 minutes a day, 4 times a week. Have bone density evaluated every other year. Get sufficient nutrition and be able to discuss risk factors. Modify the home work environments to avoid injury. Because we know that these people are very, very much at risk for fractures. All right, let's go on. And our goal really is to maintain safety and prevent injury, implement safety precautions, avoid restraints on hospitalized or long-term care client, encourage the use of assistive devices, and teach older client about safety, fall prevention, and relieve acute pain, suggest application of heat, and suggest over-the-counter anti-inflammatories. Promote balanced nutrition, teach women, men through age 35 about calcium needs, encourage postmenopausal women to maintain calcium intake, and teach patients about medication use. Inform clients that calcium absorption requires sufficient levels of vitamin D. That's a very important part of the process of absorption of calcium. And then lastly, to encourage exercise, ensure safety before starting exercise program, teach clients about weight-bearing exercises, and to determine a client's interest. Plan exercise regimen in sync with preferences, and promote healthy behaviors, smoking cessation, avoid and limit alcohol, and limit caffeine intake. So that's about osteoporosis as well, okay? So let's look at this Appendix 55 on osteoporosis. Mary Bell is a 65-year-old Caucasian female who comes to the clinic with back and hip pain. Her past medical history includes COPD with intermittent steroid use, hypertension, depression, GERDs, and tobacco use. Miss Bell lives alone, cooks for herself, has no family living nearby, and does not exercise. The nurse observations are that Miss Bell is a frail, elderly-looking woman who is in moderate pain and moves cautiously. Her gait is unsteady. So let's look at these questions. What risk factors are present, either modifiable or unmodifiable, for osteoporosis and possible fracture? So let's think about that. Modifiable risk factors for osteoporosis include disordered eating, calcium deficiency, vitamin D deficiency, substance abuse, a sedentary lifestyle, and prolonged use of some medications. For Miss Bell, modifiable risk factors include smoking, use of steroids to treat her COPD caused by smoking, cooking for herself that could lead to disordered eating, lack of exercise, and of course, menopause. And her non-modifiable risk factors for osteoporosis would be an unknown family history of the disorder. She's age 65 and she's of the Caucasian race. So let's look at safety risks that are present for Miss Bell. They include current back and hip pain. She lives alone. She smokes and cooking with being unattended to, history of depression, frail structure, and an unsteady gait. All ways in which she could fall and be very unsafe. So what further interview questions should the nurse ask? I would really look back and see what was her maximum height. Did anyone else in her immediate family experience or have unexplained fractures? Was anyone else in her immediate family ever diagnosed with osteoporosis? And what amount of milk and dairy products do you consume each day? And how much time do you spend out of doors in the sunlight? And what types of physical activities do you enjoy or like to do? And how long you've been smoking? Probably long, because she has already COPD. And how many cigarettes do you smoke? And what efforts have you taken to quit smoking? And what dietary supplements do you take each day? And what action do you currently take to control your hip or back pain? And have these methods or actions been effective in controlling your pain? And do you take any over-the-counter medications or preparations to control the hip and back pain? And do you use any assistive devices in your home or when you go outside and mingle socially? So there's a lot of things that we could ask her that give us a clearer picture on, how advanced and progressed her osteoarthritis is. All right, let's look at question 4. What are 2 nursing diagnoses for Miss Bell at this time? Obviously 2 that I can think of. She's definitely acute pain and definitely risk for injury. All right, question 5. What independent nursing interventions can you perform to help make Miss Bell more comfortable and safer while in the clinic? Obviously, to help with her pain, we can offer a chair that is more comfortable, offer pillows to support her areas of pain, and offer a heat source. And to help her with ambulation could keep her safer, and really suggest that she does use like a walker or a cane as well. So what tests do you anticipate will be done for Miss Bell at this time? Probably complete spine and hip x-rays, scheduled for a complete DEXA scan. And let's draw some blood work again for alkaline phosphatase, vitamin D levels, and her serum bone GLA protein level. Okay? All right, let's finish up this case study. All right, Miss Bell's score is found to be minus 3.2 in the spine and minus 3 in the hip. She continues to have pain. Miss Bell has been started on a bifosphonates. Her COPD is also exacerbated, and she is starting back on her steroids. When she comes back to the clinic for a follow-up, she is coughing deeply. So what interview questions would be a priority to ask at today's visit? Interview questions that would be a priority at this time would be, are you taking the bifosphonates medication as prescribed? How long will you be taking the steroid medication? How long have you been coughing? Has your back or hip pain changed since you've been coughing? And what are you using to control the hip and back pain since your last visit? Are you using an assistive device when you walk? Have you considered smoking cessation actions? And have you begun any weight-bearing activities? Have you increased or changed your intake of dairy products since your last visit? Are you taking the prescribed calcium and vitamin D supplements as prescribed? You might want to also look up to see what these numbers mean as far as what came back with her x-rays as well. All right, question 2. What teaching can be done to help Miss Bell understand her diagnosis? I would talk to her about smoking, but that's something that we really need to do in a very sensitive way to explain the effects smoking has on bone demineralization. Talking about weight-bearing activities to help strengthen her bone structure, but that can only be done when we can get her respiratory status in control. She seems to be in a little bit of distress with her exacerbations. She's not going to feel much like, lifting weights. And being sure that she understands the need to take her prescribed calcium and or vitamin D supplements as prescribed and to become compliant with that. All right, question 3. What added risk related to fractures are present with Miss Bell's COPD exacerbation? Because she had this exacerbation of her COPD, she has been prescribed a course of steroids, which increases her risk of developing glucocorticoids-induced osteoporosis and spontaneous bone fractures. Steroids can directly affect bone cells by slowing the rate of bone formation. They also interfere with calcium metabolism in the body. So what type of medications can aggravate Miss Bell's GERDs and why? Well, the most common drug class for treating osteoporosis is, as you're learning, your bisphosphonates. These drugs are structural analogs of pyrophosphonate, a natural substance that inhibits bone resorption, and biphosphonates inhibit bone resorption by suppressing osteoclast activity, increasing bone density, and reducing the incidence of fractures by about 50%. Sometimes we see the adverse effects of these medications, such as nausea, vomiting, abdominal pain, and esophageal irritation. This can aggravate the manifestations of GERDs in Miss Bell, and because this medication is poorly absorbed, it should be taken on an empty stomach. She has experienced some esophageal burning after taking the medication. So, let's continue with Part C of this evolving case study. She falls while out grocery shopping and is brought to the ER with a fracture of L3 and L4. She is admitted to the medical surgical floor for several days for conservative treatment, focusing on alleviating her pain and preventing further injury. So question 1 is, what is the anticipated mortality outcome for a spine fracture versus a hip fracture? Vertebral fractures may occur more than twice as often as hip fractures in the client with osteoporosis. Vertebral fractures, however, have not been shown to increase client disability or mortality, but the persistent pain and associated changes in posture may restrict the client's activities or interfere with her normal activities of daily living. Question 2. In the hospital, what other team members may be called in to help with Miss Bell's care? A dietitian, physical therapist. Just want to be sure that when she does go home that her house is safe, and someone should be able to make that assessment upon discharge. So question 3, develop a discharge plan for Miss Bell that includes safety and medication education. Again, home safety would involve being sure that her house is free from all scattered rugs from floors. Make sure that the stairs are all cleared of any items. Ensure that the floor areas are well lit. Install or encourage the use of grab bars in the shower stalls or in the bathtubs. And install or obtain elevated commode seat. And encourage the patient to wear non-skid shoes at all times so she doesn't slip. And as far as her medications, take prescribed biphosphonate medication as prescribed, and this may mean taking the medication immediately upon waking in the morning with a full glass of water and sitting up for 30 minutes before eating breakfast. And take calcium and vitamin D supplements as prescribed, and this will vary according to the type of calcium supplements. If it's calcium citrate, they should be taken with meals, and calcium supplements should be taken in divided doses 2 or 3 times a day, and vitamin D dosage may be prescribed to 80 to 1,000 IUs each day. All right, and I know you're learning all about those in your pharm class as well. So lastly, while in the hospital, Miss Bell is treated with heparin. Comment on the use of long-term heparin therapy for Miss Bell. Heparin therapy will increase bone resorption, and prolonged use of heparin is associated with osteoporosis, and the long-term use of heparin can exacerbate her condition. So we want to think about that. All right, so that is our case study with Mary Bell. All right, lastly, let's go over Appendix 56, another case study that involves osteoporosis. Mary Martin is a 75-year-old female who was recently widowed. She has limited income because her husband's pension terminated when he died, and she's moved in with her son, his wife, and their 3 teenage children. Mary has cataracts and glaucoma, for which she sees an ophthalmologist on a regular basis. Otherwise, she's in good health. She goes to the community fair with her friend. While at the fair, she has a bone density screening performed and is told that she needs further evaluation for low bone density, a finding commonly associated with osteoporosis. In a follow-up visit with her primary care provider, Mary is told her bone scan shows evidence of decreased bone mineral density consistent with osteoporosis. She is told to increase her activity for weight-bearing exercise, to increase her calcium intake to 1,500 milligrams a day, and to take vitamin D supplements. She's also given a prescription for alendronate or Fosamax. So let's look at this situation and what teaching would we provide. Again, she is told to do weight-bearing exercises like walking, and this activity will help increase osteoblast growth and activity. She will have to be educated on Fosamax and its side effects, and that she needs to sit or stand for 1 hour afterward. She will also be told about the necessity of taking calcium and vitamin D. All right, question 2. What outcomes are appropriate for Mary? She should pretty much do well if she follows this prescribed regimen. This will help in preventing fractures and will promote good bone health as well. And question 3, what recommendations will the nurse make to reduce the risk of injury when assessing Mary's home? Again, like we said for our Miss Bell, making sure that her house is safe. Suggest removing any throw rugs, being careful around any animals, holding the rails when climbing stairs, and having furniture that is accessible and safe, and make sure that she has clear pathways as she walks, and to make sure that she has shoes that are safe that don't cause her to slip and fall as well. So just a little extended, repeat of information that we somewhat discussed with our other patient, Miss Bell. So let's look at these review questions on osteoporosis. Question 1, the physician prescribes Fosamax and Actonel for a 65-year-old female for which of the following purposes? And so does it inhibit osteoclastic activity and decrease the incidence of vertebral and non-vertebral fractures, decreasing spinal fractures and preventing formation of thrombosis? Number 3, binding bile acids in the GI tract to enhance calcium resorption. And 4, to suppress inflammation in the normal immune response and enhance metabolic processes. Obviously, the answer to that is number 1. It inhibits osteoclastic activity and decreases the incidence of vertebral and non-vertebral fractures. And the rationale behind that is these two meds are potent drugs that inhibit osteoclastic activity and help to decrease the incidence of vertebral and non-vertebral fractures in postmenopausal women. The actions of these drugs do not include preventing thrombus formation, binding bile acids, or acting as an anti-inflammatory agent. All right, question 2. A 67-year-old client asked the nurse about osteoporosis. The nurse responds that osteoporosis can be defined as, you should know this, loss of bone matrix, new weaker bone growth, loss of bone density, and increased phagocytic activity. Now, you guys should know this. I can hear you yelling it out to me. And of course, the answer is, of course, number 3, loss of bone density. And the rationale behind that is osteoporosis is a loss of bone density. Specific causes in older adults include vitamin D and calcium deficiencies and the use of glucocorticoid drugs. Phagocytic activity is not a contributing factor here, and osteoporosis is bone degeneration, not growth. Bone matrix refers to the structure or scaffolding of the bone, which is not lost. The bone softens. All right, question 3. Although all of the following nursing diagnoses are important when planning care for the patient with osteoporosis, which will the nurse select as most significant in terms of long-term disability? Great question. So, number 1, chronic pain. Number 2, risk for falls. Number 3, activity intolerance. Or number 4, acute pain. Now think about it. This is about which will the nurse select as the most significant in terms of long-term disability. So I hope you're screaming out the answer to me here. Of course, it's risk for falls. That will incapacitate a person when they fall and fracture something with a possible fracture. So the rationale behind that is the most significant nursing diagnosis in terms of long-term disability, because falls that would result in no injury to the healthy adult may cause fractures to the client with osteoporosis. Chronic pain, acute pain, and activity intolerance are important, but in terms of disability, falls will have the most impact on the client's condition. Question 4. The nurse determines that teaching goals have been met for a patient with osteoporosis when the client states, number 1, I can stop taking calcium since I am taking fluoride. Number 2, I can smoke half a pack of cigarettes per day. Number 3, I should do isometric exercises every day. And number 4, I will walk 1 mile a day. Obviously, the answer is 4. I will walk 1 mile a day. Remember, we want to do weight-bearing exercises, not isometrics, to help prevent bone loss. Walking is a weight-bearing exercise. It is important to maintain adequate calcium intake when taking fluoride, and smoking should be stopped altogether. There should be no compromise with that. All right, number 5. The nurse includes which of the following when teaching the client with osteoporosis? About preventative measures for complications of osteoporosis. And the choices are number 1, infection, number 2, blood clots, number 3, fractures, and number 4, contractures. That's obviously fractures. Very good. Answer 3. Let's look at the rationale. In clients with osteoporosis, fractures are a potential complication due to decalcification of bones. Infection, blood clots, and contractures are not necessarily associated with osteoporosis. Well, I hope these help you as we, talk about the case studies and give you a real-life situation in which these people have these unfortunate problems, but really looking at these people and looking at, their risk factors and what are some of the ways that we diagnose it, what are their manifestations, and how do we treat these problems. So that's what I want you to put together when you look at these exemplars. All right, if there's any questions, let me know. I've really appreciated your attention, and enjoy. And this concludes my lecture.